Welcome everyone to this 73rd seminar of the Global Health History series. People who are sitting in the back, please come up and sit at the table and maybe leave those chairs for people who come a bit later. Thank you. We're following our normal format. We have two speakers on the topic of medical tourism. Each speaker will make their presentation and then we'll open it up for questions. As usual, the seminar is broadcast on the internet as a webinar, so we'll have an audience also listening in. So when at question time, please make your questions to the microphone and give your name so that people who are listening can also follow the conversation, and people who are listening via the webinar, you're free also to ask questions, and we'll also leave some time for that at the end of the seminar. So, as I said, the topic is medical tourism. Our two speakers today, the first speaker is Dr. Neil Lunt, who is a reader in social policy at the University of York. Neil has his background is in politics, where he was got a degree at Durham University, and then he did his doctorate in New Zealand in social policy at Massey University. He's recently been working with a group at the London School of Tropical Medicine on some empirical work on medical tourism, and a report will soon be published through the National Institute for Health Research in England on the results of that research. So I'll first ask then the first speaker to make his presentation. Thank you.
So it's going to get wonderful. Thank you. Thanks very much. It's great to be here, have the opportunity to talk with interested parties about medical tourism. I'm going to make some broad observations. As the introduction has outlined, I've been undertaking some empirical work with colleagues at the London School of Hygiene and Tropical Medicine, Richard Smith and Joanna Hannafeld, and reflections today are part of a broader programme of work, one of which is an empirical study that is due out later this year, funded by the National Institute for Health Research, but there's also a range of other interests that we've sought to bring together in terms of thinking and writing and presenting about this particular aspect. So my presentation will have four parts: some background, some comments on patient choice, patient decision making, a little bit of commentary on risk and external quality assessment, and then I want to move more broadly and think about some wider programme and system considerations. In terms of locating medical tourism, it can be seen as part of broader patient mobility, and that's got many forms. We think in terms of retirees moving overseas and drawing on local health systems. We think about holidaymakers needing health care as part of being sort of accidental medical tourists. Then clearly medical tourism is part of a wider set of ideas. We're going to talk today about one variant: medical tourism, medical travel, global healthcare, which seems to be receiving a great deal of attention. And although a number of commentators would try and point us towards the sort of historical continuities in terms of individuals travelling out of jurisdiction for treatment and recuperation, I think what we're seeing as a result of globalization is certainly quantitatively and qualitatively different. The role of the internet and the contribution of low-cost airlines, for example, are helping to intensify a number of developments in terms of medical travel. There's also an interest in sort of broader sort of program system level consideration that actually it becomes increasingly difficult to identify individual countries who do not see some opportunity or have some aspiration in terms of developing their domestic health system to treat visitors and those from outside of their particular jurisdiction. A definition is given there in terms of consumers electing to travel across international borders, receiving some form of medical treatment, and there can be a whole range of medical services: fertility treatment, dental care, elective treatments. I know that Ed will talk about some issues around transplantation, and there's a whole range of treatments, all perhaps with different considerations and nuances. And although precise numbers are not available, it's certainly a thorny issue in terms of what size are these flows, where are they going from and to. It is possible to identify some patterns of travel that are fairly well established. So if I think of the UK, I can identify medical travellers going to Poland, Spain and Hungary. We can also identify, for example, Australians travelling to Thailand. Within North America, we can think about flows in terms of Costa Rica and also residents and citizens travelling to Mexico, for example. One of the things that the team is starting to recognise is this issue of familiarity and cultural similarity being really important in terms of how and where services are targeted, and it's a point I'll return to. Given this talk within Europe, it's also important to distinguish what I'm going to talk mostly about here in terms of out-of-pocket or insurance portability medical tourism from cross-border rights that EU citizens have. And the rights have been codified in terms of the EU Patient Directive, and that gives EU citizens the opportunity to travel to another EU country, to have treatments for which they're eligible, to have those treatments in another EU country, and for that cost to be reimbursed by their national health funder. So I call that sort of a citizenship approach to medical travel. Comments mostly today are going to be about medical tourism considered more as a sort of consumer development, whereby individuals are paying out of pocket or perhaps using insurance portability to fund their treatment. And as I say, there's a range of activities: dental, cosmetic, IVF and elective surgery for which that occurs. As a social scientist, we often focus on things that change and difference and are novel. And I think it's always important to recognise that we've got to put that in context and to be clear that most patients, the world over, prefer to be treated as close to home as possible. So medical tourism, when we put it in that broader context, is a sort of an unusual phenomenon. And we've got to really try and identify the boundary commissions to explain the unusual. What is it that makes certain groups under certain conditions travel out of jurisdiction to receive treatments? Now, certainly my own work and the work of other scholars in Australia, in North America, has started to identify the reasons for medical travel, including the following. That for some treatments, some groups, cost is a really significant consideration. For other sorts of treatments, and I'll give you a couple of examples in a moment, it's perceived quality that's seen to be the main driver. Cost is important, but it's certainly not the main push for travelling out of jurisdiction. For some, it's about the speed of access to particular treatments, and for other sorts of treatments, it's the lack of availability or legality of particular interventions. So we think, for example, about various forms of fertility or also some forms of transplant activity. And confidentiality, the notion of not wanting individuals to know that you've been away for a nip or tuck or whatever sort of intervention you've had. And far less important, as we'll come on to see, is this idea of combining tourist attractions with procedures. You know, the notion of medical tourism may give an indication that it's medical treatment and a form of tourism. But as we'll see, medical treatments are far less concerned with the notion of tourist service and delivery. And finally, diaspora of particular groups is really crucial in terms of trying to make sense of these flows. And all of these things differ across treatments. To just give you two examples, if we take cosmetic surgery, then there is strong arguments to say that there's a price sensitivity there, that for cosmetic patients, cost is really key consideration. Why? Because there's a mindset and a set of expectations in terms of accessing cosmetic treatment. Within the UK, for example, it's not available through the publicly funded health system. You've then got the opportunity to purchase as a private patient or to travel overseas. And so for the decision making around cosmetic procedures, you know, to seek cosmetic treatment is to seek private treatment, and that pushes a number of individuals to a certain decision about travelling overseas. There's also some very interesting things about socio-economics and decision-making around cosmetic tourism as well. The idea that for certain groups of the population, investing in their body is a really important social consideration, because as sort of capital, it's what they see as being the only thing that they've got in terms of activities in a broader social context. Let's have another example. We think about the UK experience of patients travelling to receive bariatric surgery. Then the UK experience through the mid to late 2000s was that there was a real postcode lottery in terms of bariatric surgery. There were long waiting lists. It really depended whereabouts you lived within England as to the access to that treatment. But in terms of proximity, there was a growing centres of expertise in Belgium, offering bariatric surgery, so with clinicians that were doing many of those procedures. And what we then can see, and some of the evidence would support this, is that bariatric patients didn't identify cost as the driving factor. Instead, it was really focused on expertise, numbers of procedures, the sorts of procedures that were being done in particular places. But I suppose more generally, decision is rarely the result of one single motivating factor, and rather it was sort of a combination of expertise, availability, being able to travel at the time to Belgium via train rather than flights and so on. And we can also broaden that comment out in terms of trying to understand decision-making for treatment, to say that, you know, cost may be important, but it's not the sole motivation. Equally important is a whole range of other things, and it's a very sort of complex decision-making matrix in terms of why and how people choose to travel to particular places. And often that complexity is not recognised by providers and national governments who may be seeking to enter what they see as a very lucrative market. Second point there is that networks are really important. We talk about this sort of market in healthcare. Well, it's a very complex market in terms of decisions being mediated on both the supply and the demand side. So, for example, individuals will take advice and receive support within their own either cultural networks or treatment group networks. So online, for example, you're considering dental treatment abroad, fertility treatment, cosmetic treatment. There's a whole range of online support groups which really serve to mediate and offer advice in terms of where to go to. A broad consideration also is that whenever you talk to medical travellers, tourism is very far from their minds in terms of what they hope to do after they've had the particular treatment completed. That, you know, recovery will be painful, it will be uncomfortable, and although the climate might be very agreeable, probably the last thing they're going to want to do is to travel to see particular tourist sites. We begin to think now about online information. Many of medical travellers, their main source of information is online, and we're in the age where people do search online. And what we've begun to recognise is that the risks of treatment aren't fully detailed. So there's this combination of infomercials where information is not clearly delineated in terms of outlining the risks for particular treatments, for particular groups of individuals. Clearly as well, the onus is on prospective medical tourists to locate guidance and advice. Primary healthcare practitioners are very reluctant to become involved in any sort of co-decision making, and the onus becomes very squarely on individual medical tourists. And when we begin to think about the online world, a real Wild West world in terms of information, there's a number of quandaries we have. What are solutions? Is it codes of conduct? Is it self-taken quality labels? Is it about educating the users in terms of how to search and how to interpret, and so on? And that is a real thorny consideration in terms of information. If we think about safety and risk and make some broad comments there. The first 2 points are really inherent in what medical tourism is. Patients travel overseas, so they're leaving the regulatory safety of their own country. They're traveling for medical treatment, and we know that medical treatment will typically result in aftercare being required. And when you take those two things together and begin to sort of unpack that in terms of experiences, well, prospective patients and actual patients that have travelled are rarely aware of where and how they can seek redress should treatments abroad, give rise to complications. And there's also a sort of confusion in terms of how many patients interpret information that they're told. So, for example, in the UK, a long-standing safeguard is that a clinician is GMC registered, and you may see a clinician registered with a GMC registration, but if they're practicing out of jurisdiction, then that as a sort of safeguard for you as a patient is really problematic, and it's how patients don't always understand those particular distinctions. So, medical tourists are unlikely to be fully informed or understand all the associated clinical risks. And the study that we'll report later on in the year will sort of detail that in more detail and in particular treatment categories. And also, medical tourists are more likely to pay heed to very soft information rather than sort of hard clinical information. So it does happen that patients look at outcomes data that try and make sort of decisions based on sort of assumptions of quality, etc. But quite often, decision making draws on far more softer information, informal networks, a perception of what the website was like, a clinician that was willing to be contacted at any time of the day to have particular concerns and questions addressed. Those sorts of things can shape decision making. And what we see looking across Europe, for example, is very little effective regulation of information, hard or soft, online or overseas. So in terms of an analysis of websites, myself and colleagues were clearly able to identify information that wasn't just subject to discussion or to interpretation, it was just downright wrong. In terms of external quality assessment, again, if we just look across Europe, there's a whole plethora of clinics and providers who have EQA and registration details displayed on their websites. But there's no clear pattern in terms of those when we look across particular treatments, dental, cosmetic, and often it's a sort of reflection that the market within Europe, a number of very small niche providers offering services, and so they draw on very diverse forms of EQA and registration. And certainly when you look at those sites, to make sense of what they've displayed there requires a particular health literacy on behalf of users. And I think it's fair to say that EQA has a very limited role in sort of signposting to patients in terms of what particular clinics have and particular safeguards as well. Let's move more broadly now and think about national strategy. Many countries have sought to invest in medical treatment and support domestic activity. Korean government is a very, very interesting example. From 2009, they identified medical tourism as a growth engine. They've undertaken a lot of activity in terms of international trade fairs and marketing and official support. They've changed visa requirements. They've allowed hospitals to market overseas. And what we see, I think, with Korea, as with many countries that have sought to develop in this field, is certain key messages. Places being promoted as very customer focused, an emphasis on marketing services as high technology and high quality, a focus on clinicians with overseas experience, and in particular settings, an emphasis on securing accreditation from international programs. But when we start to look at some of the national activity, again, we've started to be a bit critical about some of the myths that we argue go around. I mean, we talk about three, and the first is that there's sort of this huge development in medical tourism, and there's great opportunity for countries to develop their particular services. And one of the problems, I could go into in more depth, but won't, is just the difficulty of actually trying to get definitions and to clarify where numbers are coming from. And what we get in the end is large numbers of sort of estimates, projections, extrapolations and guesstimates. And there's a real difficulty in terms of trying to interpret figures, particularly when they come out of private hospitals, in terms of the volume of activity that they are engaged in. So the numbers. There's also this issue about global flows. You could be led to believe that there's a sort of a globe that is crisscrossed from every point in terms of medical travel. But actually, more typically, they're sort of very strongly bilateral flows or relations. And so what you could say is, every country might be interested, but actually far fewer seem to be benefiting from particular activity. And then the third point, take those first two points of consideration, is what then should be the government role? And you could argue that with all activity it should be strategic and evidence-based. Well, if you're not very clear about the numbers, if actually there might not be a global sort of set of opportunities, then actually that has a bearing in terms of how marketing budgets become directed. And particularly of interest is the fact that these activities have been supported by public taxation in terms of growing perceived opportunities. And I think it's also time maybe now to take a deeper look at countries that actually have invested in recent years and begin to ask the questions, what have been the knock-on effects in terms of that activity. And I also think we should begin to look far more at, as well as success, examples of failure. And I think there's some very interesting examples of investments in different parts of the world that clearly haven't resulted in anticipated gains, and begin to think about how we can learn from that. So we've got there three myths, and it may well be that emerging markets are far more sort of mundane, or that countries that are looking to invest in medical tourism, they may not be successful in receiving the patients that they anticipated, but they may be successful in receiving patients who are far more familiar visitors, perhaps sort of diaspora, second generation patients. There's also a risk that when we talk about medical tourism provision, we forget that it's not context-free, and that countries work within particular structural and cultural sort of constraints, and we have to look to the systems that are inherited to really make sense of how and whether opportunities do exist for particular countries. Just a final point, and this is particularly draw on sort of some of the work around the London School, is to ask, given all of this debate around opportunities and medical tourism, what's the evidence from low and middle income countries? And there's been very little research evidence that's begun to identify at that country level what some of the implications have been of seeking to attract medical tourist patients. So we've got really three key pieces there. In Tunisia, Dr. Siddiqui's work in the Middle East 2010, and then work in Thailand. Just to move briefly, the reflections of looking at that evidence would be that, there's a high context specificity, but there may seem to be some suggestions that there's a possibility of alleviating genuine shortages in health services and skills, some evidence that there's a small contribution to overall GDP, some job creation, including within the health sector, but in some cases evidence of displacement in terms of moves from the public sector to the private sector, and then increases in price, which has particular implications for domestic populations. So, there's a clear concern around some of the equity impacts and how and whether it's possible to mediate those. And so beginning to sort of think more broadly about medical tourism or health trade is, to begin to pose some questions in terms of health system challenges. What is the role of a medical tourism strategy in terms of a public-private mix and health worker return within particular countries? Do we know enough about the role of the private sector in low income countries in terms of the provision of healthcare and how that operates? And do we know enough in terms of how there are trickle-down benefits in terms of training, surgical learning curves, and sort of development of specialisms if countries do open up activity and seek to attract visitors from overseas for medical treatment? And then we begin to move on to concerns about regulations and risks and how quality then can be assured. And the work of Richard Smith, for example, to begin to explore whether bilateral agreements might be the way, and some sort of cost activity there in terms of potential benefits of bilateral agreements between countries in terms of health trade. The final point, I think, is about how to mediate possible negative impacts, especially the inequities in access to services. Overall, we don't know enough at the system level. The sort of lack of evidence at the system level is quite significant, and also the sort of causal pathways in terms of how investment delivers opportunities or not within particular low and middle income country settings. And so, a final quote just to finish, it was from 2 years ago, a review we did for the OECD, and we said that the evidence base is scant to enable us to assess who benefits and who loses out at the level of system, program, organisation and treatment. And I think we're a little bit closer to understanding the level of organisation and treatment, but perhaps less so in terms of system and program level implications.
Thank you, Dr. Lunt. That was a very interesting, informative presentation, and I'm sure there'll be quite a few questions coming, but we'll ask people to hold their questions for the moment while we listen to our second speaker, is Dr. Edward Kelley from the Patient Safety Program here at WHO, and I'll ask him to give a WHO point of view on this topic.
Thank you, Hooman, and it's always an advantage of giving the WHO perspective on this, because we don't have to cover lots of ground that the actual expert in the room has covered. The disadvantages on both occasions that I've spoken at the Health History Seminar, vastly inferior in terms of knowledge on the subject to the person who's just spoken to you. But in terms of WHO's perspective on this, I think there are a number of key issues, and the patient safety, I'll come to why, in particular, the patient safety program has a bit of an interest in this area as well. I think primarily, you've already heard Neil talk about the issues related to the numbers. So from just a numbers perspective, it doesn't immediately present itself as one of the top priorities for WHO to be concerned about. But from a sort of a whole number of other perspectives, I think there are some arguments for this. One, there's a systems organization issue. Right now in WHO, there's a big push around, and we just had a 2-day meeting on it that I shared, on a new work on integrated people-centered care. So what does it mean for an integrated healthcare system to, what does medical tourism mean? Is that part of care integration? Or, as we like to divide the world into member states, i.e. countries only exist insofar as they are members of the WHO, you know, do national health systems have this integrity that is defined, and that integration is only related to ends at the boundaries of that country? There's also financing and health markets perspective. WHO leads and works quite a bit with the OECD, and I'll show some OECD numbers to which Neil's well familiar. There's thirdly, a safety and quality perspective, I think, on this, as well as an ethics perspective that's related to those 2 points of view. We work, for instance, with, as one of our collaborating centers until just recently, the Joint Commission International, which is one of the institutions that does some of the most frequent accreditations for these institutions that Neil was talked about in terms of where people seek care. But I think the last bit, and with what I'll end with, is really the patient and family perspective. And I think one of the things that we need to consider going forward on this issue is that each of these individuals that go to seek care overseas, there's an individual family and an individual patient behind it, and very quite complex motivations that are part of that. And for our work in patient safety, we've always put the patient and the family at the center. And there's quite a bit of interest these days in patient and family engagement. So I think from that perspective as well, there's a valid point to bring up. I won't spend so much time covering some of the ground that Neil had already covered. You know, the medical tourism, the main point being that outside of his work and a bit of work in the OECD, there's not such a broad agreement on the definition of medical tourism. There is some disagreement on the numbers in terms of countries counting foreign patients' visits to hospitals, whereas others count the entry of individual patients into the country. And as folks who work in statistics know, there's quite a variability in terms of how countries record nationality, country of origin, and these types of things in national databases. And this kind of thing, as someone who used to work at the OECD, gives people at the OECD endless headaches. So some of the numbers we have, unfortunately, come from companies that are providing consulting services to countries that are trying to build their medical tourism industry. So you have to take a bit of, with a grain of salt, some of the things that are out there. With no aspersions to, I have a brother-in-law who works at McKinsey, but McKinsey and other places, Deloitte and others, have published a number of bits of information on this. There's a general exclusion in many of the numbers of expatriates who are seeking care in their country of current residence. So for me, seeking care from my doctor in France where I live and my current residence, usually that's excluded, and then frequently there's a subtraction of emergency cases. So medical travelers would constitute a subset of the total number of foreign-born individuals seeking care. I offered this conceptual framework for globalization and medical tourism principally as a frustrating effort in those of us who wear glasses, but then secondly as a bit of a framework for the issue, and that this, I think the medical tourism question is not enough pictured in this broad issue of globalization and health. And if you were to take a country like the United States, for instance, just even last year, working with colleagues from the FDA, we're working on the development of a new medication challenge. We do these global patient safety challenges. The third one, which will be launched next year, is on medication safety. And if you look at the numbers, the FDA, for instance, used to basically take the stance that they would regulate their way out of any quality problems. That's not a uniquely American approach, but it's something of an American approach. And they receive now, the latest figures are 20 million products from 300,000 different factories in 150 countries. So there's no way you will regulate your way out of that. Globalization obviously has come to healthcare a long time ago. And even now, in the human resources sector, globalization has come. For instance, again, from the United States, 1 in 4 practicing doctors in America receive their training overseas. So obviously, even medical education is an international issue. That's something in the patient safety program we've worked on in terms of a global curriculum, and we hope that this challenge will help develop it. But just to point out here, if you think of it from these 3 bottom boxes of an institutional perspective on globalization, there's an economic and social as well as a technological perspective. All of them have, as Neil was just pointing out, some reflection in the medical tourism phenomenon that's existed. Some of the numbers now, having given all of something I used to hate when people would do this, which is they give lots of caveats on numbers and then they flash a bunch of numbers up as if they're the absolute truth. But just to give some perspective of some of the estimates that are out there, the size of the medical traveler patients, this in terms of the percentages that are driving, from that framework that I just mentioned, driving some of the medical tourism, advanced technology, better quality care constituting a majority, but there is also a significant portion, particularly in this area around things like transplantation and waiting lists that I'll come back to, that motivate patients. Another issue is cost. Right now, and you mentioned this, in Europe, the Cross-Border Care Initiative is right now looking to move into its implementation phase, where there will be some exploration, which no doubt will cause lots of arguments from people in Brussels, about looking at centers of excellence in different countries that are performing for certain volume-sensitive procedures, i.e. where volume makes a big difference to the outcome, to explore whether it would make more sense that a referral center that happens to be in Belgium could not just serve southern Belgium, but could also serve northern France, Luxembourg, and other parts, and the patients could seek care there. In the U.S., there's lots of exploration. We have colleagues for the program right now who are working with Google, other companies, and it is cheaper for them, they've gone through the numbers, to take a patient that lives on the West Coast, bring them to Cleveland, to the Cleveland Clinic, which has world-class cardiac services, have their cardiac procedure, they put them up in a hotel, fly them back, all for cheaper than the on average cost that they would have for that patient to seek care in Los Angeles. That's the same feeling. Now that's at a quality level, because obviously, relatively speaking, costs of labor in Los Angeles and Cleveland, call it Cleveland with anyway, Cleveland's a fine place to live, but it's not, maybe not Los Angeles, but anyway, it's a little bit less expensive. But the other driver there is the cost of labor. And so you can see these numbers down below in terms of coronary artery bypass graft, hip replacement, knee replacement, some significant numbers, although again, estimates this time by the OECD. The OECD has also made an estimate of sort of imports and exports of, that's how they term it, of these types of things. This gives an idea of basically how patients would be seeking in terms of countries that are bringing patients in. This is at a percentage of healthcare expenditure. So it's mainly to highlight 2 things. One, as with all things, there's great variability between countries. And there's quite a bit of change in this number year to year. On the right is the change from 2004 to 2009. So the biggest change surprisingly, is Estonia. Although a number of other countries have high numbers as well. In terms of the exports, i.e. the number of where their services are being sought there, this gives us some idea of that variability as well. The other piece that I think is important to highlight here, this is only OECD countries, and I think in terms of what WHO can offer, we're working, for instance, right now on a global report on quality and safety. The OECD has done that for the OECD countries, but it's never been done internationally? Is there some greater good in looking at some of these numbers in a more systematic way in a partnership with the OECD? That could be something to examine. This gives a bit of an example of medical travelers by point of origin. This comes from a survey done for about 20 countries, again, done by McKinsey. It gives basically, although it's a bit of a complicated chart, it gives you the picture that, again, there's quite a bit of move from certain regions to certain regions, underscoring what Neil had mentioned, that there are certain relationships between countries and between different regions. You can see movement between Latin America and North America. But it's also underscoring one of the conclusions of their study was that it's no longer solely a sort of northern hemisphere move to southern hemisphere. I mean, you can see quite a complex relationship here. There's lots of movement even within Asia. The 93% of the patients there were moving just within other Asian countries. So the movement around may not have come to all regions, but it's in terms of WHO's work, but it's of concern to all countries now. You could look at a typical country. We pick the United States solely because it's a chance for me as an American to remind my colleagues that America actually does have a health system, despite the fact that as of yesterday we were completely shut down. But in any case, this is a bit dated because it's 2008, and it was looking at some of the projections in patient flow. And again, underscored that it is projected to grow. Basically, most of the estimations on that upper bound, I think, were highly optimistic. It's been seen that it's not growing as quick, and this is in terms of the patient demand. If you look at the cost estimation, it mirrors that in terms of spending abroad over and looking forward into 2017, and then the lost U.S. domestic spending in billions of U.S. dollars. Now, again, this goes back to my point earlier. There were very small numbers. There were percentages of the OECD numbers. Those were percentages of overall health spending. They were in the sort of 1, 2, at most maybe 7% of spending for like Luxembourg. This is in the context where in the U.S. there's massive healthcare spending, and it's a very small percentage in terms of the overall market. The growth in 2009, when some of this numbers were taken, of estimates of total spending about just under $2.5 trillion, and that's expected to go to $4.5 trillion in the coming years. So still, overall, even though the big numbers, the percentage of overall spending is quite small. Just to touch on one piece that we often don't think that so much of, Neil mentioned this earlier, that there is active exploration by insurance companies into this type of model, principally, based on their business model, from the idea that this could offer better patient experience but could drive down costs. Now, the issue is, legally, there are quite a few barriers, which I'll come to, but these are all just a few examples of programs operating, for instance, in the United States that are looking actively at subsets of their beneficiaries who might benefit from services overseas. Occasionally there are special relationships, and these have been cultivated by private hospital chains in some cases, Apollo hospitals, other hospitals in Thailand, looking at specific arrangements that are bilateral. Now, Neil mentioned the cross-border initiative, and it's only just come back to underscore the piece from our previous, my previous slide, that it's not a uniquely North-South institution, and also not uniquely sort of kind of rich Gulf states coming north, or rich Americans going somewhere else. That there is this aspect of institutionalized cross-border care that's important to remember, and will increasingly become an issue, less an issue for very large countries and bigger issue for Europe. But it's quite the question on quality and safety right now, we've worked quite closely with the individual who used to be with the Spanish Ministry of Health and is now in Brussels, in charge of putting in place sort of what's going to be the procedure for judging these centers of excellence where people can go across borders in Europe It's quite a technical and administrative and political nightmare. It's sort of all those issues that you would never want to get involved with, but for which WHO probably needs to consider its own position on. In terms of WHO's, governing body documents on this topic, we have not, for a lot of the reasons that I mentioned earlier, really dealt with it very much. There are a number of resolutions. This is one, 59.26, on international trade and health, that encourage, the analysis of implications of international trade regulations on patients seeking care, that encourage member states to create constructive and interactive relationships across public and private sectors. A lot of very facilitative language, but nothing that is extremely definitive. I'll mention very quickly this related issue, and I want to be careful to just say that it's very distinct from, as Neil mentioned earlier, very distinct from this medical tourism trade. But given that the program, the patient safety program, is now housing the transplantation work that WHO does, there has been for many years, and there are a long list of resolutions on this, on the issue of transplant tourism, more related to organ trafficking. And this particular issue, on transplant tourism and organ trafficking, the picture is that organ trafficking, is really laid out in terms of mapping financial gain related to the organ, consent of the donor, and a transplantation outside of the established system. These are the key elements of the definition of organ trafficking. Whereas transplant tourism typically involves the donor, the recipient, or both, and crossing national boundaries in order for the recipient to access a trafficked organ. So you can see it's quite distinct, but a related phenomenon of cross-border healthcare, in a word. And motivations, it's included in that slide that I mentioned earlier about waiting times. This gives a bit of a picture, incomplete as it is, but this was presented. WHO every year, or sort of every other year in typical, has had these global consultations on transplantation. There's another global forum coming up this year, and has relied on the members of the forum to provide information from special studies. It's something that's not currently being collected, but there's a big effort by the team right now to look at installing transparency efforts and global tracking systems. The Notify project that Luc Noel and his team have developed here at WHO with collaborating centers in Italy and elsewhere is looking at tracking both incidents as well as trying to push for the establishment of a numbering coding system, basically, that's termed ISBT 128, that will be able to track organs across countries. Right now, it's quite unreliable, the data we have, but you can see they're not massive, but there are marked differences between some of these countries. And given the moral issue and safety issue, but especially the moral and ethical issue, that's a high priority for WHO in terms of previous World Health resolutions, and there'll be actually an update at this EB on the past resolution. The Declaration of Istanbul was one of the ones that grew out of some of this work, where participants meant to push for a global declaration on the issue of organ trafficking and transplant tourism, and to push organizations to try and address this. Now, for the patient safety program, our concern with the issue of medical tourism stems to a larger transformation of the program into a new department, the service strengthening service delivery. That's the intermediate name. If that ends up as our final name, that would be, we'll see. But right now, looking at a new strategy that not only looks at safety, but looks at broader questions of service delivery improvement and quality, spanning a range of issues from these questions of tourism, transplant tourism, and medical tourism, as well as more what you term bread and butter issues of patient safety improvement and quality improvement. Then also the issue of integrated people-centered care, all of which this issue somehow, as I mentioned earlier, to start touches on. Some of the legal and ethical and then safety questions that come up related to that broad mandate I mean, there's the question of the impact on the fair distribution of medical resources. There's lots of questions as to whether people in particularly public finance systems should be using public funding for receiving care in private facilities overseas. You know, is proper contracting done? You know, what's the issue with dealing with malpractice claims for hospitals that are overseas, and quite importantly, what are the local laws and regulations to deal with malpractice issues? And there's, although we didn't spend too much time, we spent quite a bit of time talking last night over dinner about this, the international sort of birth tourism, the large numbers of patients now in this one particular area, relatively, in this one particular area, looking at IVF treatment overseas. India in particular has had a number of articles just written on it recently. And then government or nonprofit organizations helping with legal assistance in the advice of malpractice. The safety issues, I think, are some of the core pieces for us, looking at both before the experience happens, the quality of the information that patients get, what sort of guidelines and guidance exist for accreditation, and how are they reviewed, then how are the norms being followed in any given procedure, the food and sort of the ambient experience of the facilities. Then there's issues of language and patient experience, and finally precautions for post-procedure care. And I think that's part of the reminder that for these patients, you know, the experience does not end.
Look, since we have colleagues online, could I request you to identify yourself when you ask direct questions to the presenters or make comments on the presentations, because they're very useful for online attendees. Comments, questions? Sir?
Thank you very much. My name is Hernan Montenegro, and I'm a health systems advisor with the new department on health service delivery strengthening to be developed. Information. Thank you so much for both presentations. Great. I want to take a little bit on the last comment of Ed of whether this kind of phenomenon can be considered like something that's more integrated, more formal, along the lines of, you know, the arrangements within the EU, for instance, on this. And I think there are, for instance, two expressions where this is possible, and I've seen it, that I think they behave differently to the main discussion that was brought here. In the small island Caribbean settings, for instance, in the Caribbean, there's a long story of arrangements and agreements among the member states of the Caribbean, the CARICOM, for instance, and they have developed what's called the shared services. So all of this is because some very small island Caribbean islands, they don't have tertiary care. So there's this formal agreements among the different islands that, okay, for instance, Barbados will receive, and it's like a referral center for another island. So all of this is quite integrated, and it has these mechanisms. And the other setting is just cross the border exchanges you have in many places that, well, some formal, some informal, but I think borders behave differently. You have a lot of borders in different places where people just, you know, walk across the border and get, you know, a care, and then they come back. And I think this is a little bit of a different phenomenon as well. So, but, and some of those are arrangements among countries as well that share borders.
Yeah, no, it's a great point, Hernan, and I think that issue particularly, you know, we wrestled recently with looking at small island states as a particular sort of case study, and as, you know, like on a related concept, the topic we were dealing with yesterday is the issue of fragile states and countries newly emerging from conflict, where again, for entirely different reasons, you don't have the ability to deliver tertiary care. So these types of phenomena, I think, are extremely important to take into consideration.
Yeah, really interesting question. I suppose for me, it prompts two further responses. Who carries the cost and who carries the risk? Because there's a little bit of similarity, I guess, in the European context. So, for example, individuals that might want to make use of cross-border EU rights, their national funder will carry the cost, but effectively they carry the risk, i.e. if I choose to go to France or Spain for my treatment that I'm eligible for on the NHS, I can have that cost reimbursed, but I don't travel as an NHS patient. So I'd be quite interested in terms of on what basis people travel, because there's a really interesting, I suppose, parallel in the early 2000s in the UK, long waiting lists for certain procedures. And because of the supply side sort of bottlenecks, the idea was to, I suppose, outsource some of these patients to Belgium, France, and Germany. And the process of contracting and due diligence was hugely onerous. Why? Because they were traveling as NHS patients with all the safeguards that entailed. So I'd be interested to hear about some of those, maybe offline, about some of those relationships.
One moment from Who Press. In a sort of world of perfect or near perfect health systems, when everyone's implementing the WHO recommendations, where basically, either health service is free or people are fully insured, there's no problems of quality, access, queues. Is there still any benefit to medical tourism? And if that's not the case, then is sort of medical tourism a criteria for the exporting country of the quality of their services? So you, as kind of indicate, the more people exporting, it's an indication of the quality of the health service of the exporting country.
I'll offer my first thoughts on this, which I guess that would be an excellent world to live in. First of all, that's my first observation. But secondly, that that absence of that being probably the reality for the time being, even in the absence of that, and where you had the perfect implementation of all of our sort of recommendations, you still, from just the quality side, you still will have varying need for particular procedures. So back to this issue of high volume or volume sensitive procedures. And you will have hospitals that perform fewer of them and hospitals that perform more of them. And for many of those procedures, the evidence is quite solid that there will be better quality at higher volume services. Now, in larger countries, they'll have the ability to develop those centers of excellence, and smaller ones they won't. So somehow, from just a quality and safety perspective, I think that there still will be that relationship, even as we move towards a sort of perfect world of WHO guideline recommendations. Then whether or not what sort of indicator that is, other than an indicator more of need rather than of performance of the health service, I think that would be a tough one to judge. I don't think you could say that, but I don't know what you think.
The side comment would be sort of the consideration of how supply of medical treatments interacts with migration, and how inevitably choice may be a culturally driven consideration. The idea of traveling somewhere for a longer period for recuperation, to combine a visit to family homeland, for various sorts of reasons as well. So even in that, I don't know, is it a flat world that you're projecting there? Even in that flat world, I think culture, social considerations are still prevalent.
Thank you, Hong and Zhao, also from the Department of Social Theory, which is administered by Ed. I have two examples. First example from the recent World Health Assembly, reported by Afghanistan delegation. But here they are talking about the foreign consumption of medical services, because in Afghanistan there's no tertiary care. So they went to Pakistan and India for tertiary care. The annual consumption is roughly $1 million US. That's a survey done in the airport. So they question the people who fly to Pakistan and fly to India, and then say, what's the reason? Basically, tertiary care. So that's reported. So that has an effect on how to design the Afghanistan health systems. They have tried to build 3 tertiary hospitals in capital so that they can retain those people and also retain those, say, $1 million each year. So that affects their system design within the country. So that's the first point I'd like to say that. And the second, in that case, you know, the medical services, foreign consumption of medical services is disentangled with tourism. So here we have to think about how to disentangle what medical services used for as a foreign consumption and what the cost for as tourist part. 10 years ago, when I was in Singapore doing the National Health Count work on there, so they say the foreign consumption in Singapore from neighboring countries, Malaysia and other countries, even people from Saudi Arabia, roughly 3% or 4% of their total health expenditures. That's huge. So lots of money. That, but also counted as of expenditures for people use their services in Singapore, not linked with the tourists. So we have to think about how to disentangle them. Then we think about how to formulate issues here. So when we think of medical tours as one single term, it's difficult to handle that. That's my observation. Thank you.
So a really good point, and I think a number of countries such as Singapore now offer really interesting sort of case studies in terms of their experiences, their aspirations, and some of the evidence as well. The point you make about medical travellers is, of course, they if they do travel for treatments, they do make use of other services, but also they don't travel alone. And we know with particular cultural groups as well, they're more likely to travel with extended family members. And in the report that's coming out from the NIHR towards the end of the year, we've done some of the costings of that, thinking about the NHS, because, you know, one of the things we often neglect is that high-end medical systems, Germany and the US and the UK, have a long tradition in terms of servicing patients from particular regions, government contracts, various agreements, and we've begun to look at what the implication is for certain hospitals, and particularly for the London health economy in terms of that value.
I mean, just not to add much to it, but I think the point is well taken. We talked yesterday about the idea that the term medical tourism is actually in many ways not such a helpful term. It's the term of art at the moment, but it really does not capture, it certainly doesn't capture some of the issues that I was talking about, transplantation, trafficking, but it also really doesn't capture those two very distinct elements of what you talked about, and actually what Hernan mentioned too about these arrangements between countries that actually don't have the capacity in those countries. It's not, I mean, tourism somehow does not capture that need for providing that service, so it's quite different.
So just following up on the last few points is, first, thank you for an excellent presentation and very informative, especially these are two areas which countries have not recognized. One is, I wouldn't call it medical tourism, medical travel. My name is Shiva from the malaria program, but I've also come from a health system background. Countries don't recognize the issue of medical travel. That's a problem. Countries also don't recognize the health care of migrants. And the largest movement in the world today is taking place with migration and people. So the access to care is an issue, and quality of care is an issue. So you have migrants on one side, and then you have the medical travelers on the high end. And I think your work plus the work here by Kelley could maybe help to move towards better bilateral agreements, as has been done or suggested, as well as getting this a little bit more in shape in terms of providing access to quality care. So I think this is very important work which needs to be taken forward in a consistent manner. But the bottom line still comes back is that people have always traveled within countries to seek care, and either the care is not readily accessible or not. So, and the problem we have in some countries, as the case in Afghanistan, I think there's a lot happening now in many countries in Africa as well, where access to secondary and tertiary care is very limited, or if it's locally available, it's very expensive and very costly. It's just like in the US. So there are alternatives, whether it may be Singapore or India or Pakistan or etc. So I think those are the reality of what's happening, is that access to care in the basic level of primary care, then the access to secondary and tertiary care. So this is driving this movement, and I think the suggestion for more work on this area and getting countries to look at it and recognize it and take strategies forward.
Thank you, and congratulations again to these interesting topics. I think those topics are quite new at WHO, and because of that, they're very interesting and exciting. My name is Isiar Larizoite, and I'm as well with the same patient safety program with a changing name now to Health Services Strengthening or something. And I think in the discussion we are talking about related issues, but somehow different issues. And maybe one of the comments would be that maybe we need to have some clarifications on the categories. There are issues that have been raised having to do with agreements between countries to provide care to different groups of population, but there is also another phenomenon, which it was my understanding of medical tourism, by which patients with an ability to pay travel to get services that they cannot get otherwise, or that they prefer to get them somewhere else. And I wanted to come back to that particular point, and one of the issues that has been mentioned here, I think you've raised, the professor from Leeds, sorry, I forgot the name, explained before that there is no much evidence on the equity aspects related to that particular medical tourism, the real medical tourism. And I think this is important, the fact that there is a major knowledge gap around that particular issue. Particularly, we understand that healthcare supply is a scarce resource. Issues having to do with the detriment of healthcare supply to the population of the countries that spend a lot of their budget on medical tourism. I guess this is something that has to be investigated. So I guess my question is whether there is not a role there for WHO, or maybe for other agencies as well, to recommend at least that evidence gap gets a little bit filled, and we get to understand a little bit more what are the implications of medical tourism for the populations that live in those countries.
Well, I think those are both very useful points and bring up, in some ways, sort of the need for more. I mean, one of the things that WHO can be good at is raising awareness of an issue as a matter of kind of global importance. It's been something we've touched on, but as I alluded to, but in sort of transversal ways. So that's definitely something to consider. And I think that this issue also of the health of migrants, like if you look in the U.S., a country that's not a stranger to migration, the reports that I used to direct there, the health of recently arrived populations was always, and access to healthcare was always, in almost every state and almost every different type of, it wasn't based on ethnicity necessarily, it was almost always poorer. They always rated lower how well they were able to communicate and how well the physicians communicated with them, and often they had poor health outcomes. So I think that is a consideration. There's I just gave a presentation to the topic of innovation, where recent work by Minister of Health of Rwanda and others in a special issue of Globalization and Health had highlighted the fact that it's for many years, well, it's a bit distinct from what you mentioned, but it's an issue, obviously, with infectious diseases, that diseases have been traveling across our borders for many years, but our solutions have been stuck in customs. And so, in some ways, our thoughts about how we've been a bit hampered in terms of our programmatic planning because national health systems have their boundaries and their ability to spend money on solutions, and sort of WHO and other international organizations thinks in this compartmentalized way about national health systems, and I think it should challenge our way of thinking about what constitutes kind of integrated care in different types of settings. And one good first way would be a better definition around some of these issues, I think.
Clearly, I think when you look back at the literature and you see the same reoccurring sort of arguments about the potential value of countries investing in such services, but then there's the gap in terms of, well, what's been the reality, and I think there's a real opportunity there to look at some of the developments in a range of places, and I think there will be a range of very different, I think one of the things is there's medical tourisms. There are some border areas, some issues, some treatments. It will be very difficult to draw a broad brush, but certainly to begin to collect some of that evidence about the implications for workforces, the implications in terms of the relationship between public and private, the implications in terms of further knock-on investment in equities and so on. Certainly important.
I think we have one online question, and after that we'll come to you, madam. You could read it out, Miriam, if it's... Yeah, why don't you read it out?
So this comes from Keith Pollard from International Medical Travel Journal. So his question is, to what extent do you think should governments get involved in controlling and regulating medical tourism? Much is driven by commercial, for-profit interests, hospital providers, cosmetic surgery providers, medical tourism agencies. Should they be subject to national or international regulation?
Go ahead. Again, with the caveat that Human very helpfully provided that the views expressed previously and at this very moment are not WHO's stance on this issue, but I think that there needs to be, if care is provided, there's an obligation based on first principles in medical care to do no harm, as well as many, many subsequent national and international agreements on this, to provide safe, quality care that is free from error. So, if there is that responsibility, there's a concomitant sort of responsibility for and accountability that would go with that. So, I think yes, there's a definite need for the regulation of services that are provided within countries, as well as ones that would be provided across countries. Currently, as we spoke about earlier, there's not, and I agree with the questioner's comment that there's a lot of supply-side drive for these services, in particular in some areas. We talked about earlier IVF, cosmetic surgery, and others. The ability, we also commented that the international regulation on this is limited to basically fee-for-service accreditation, and then consulting services that go with that accreditation to try and achieve that accreditation, which some would call a conflict of interest. But the issue I would just underscore is, so we have incomplete systems right now. They do need to be better. There definitely needs to be something there. But in many ways, most national accreditation and national kind of report cards or subnational report cards that exist on hospitals, the U.S. loves this kind of stuff. Every hospital you go to talks about where it is in U.S. News and World Report's listing of hospitals. there's no sort of guidance or standards for that type of reporting. So there's lots of quasi-accreditation and regulation that's going on out there that mostly patients have no idea what is really to be believed or not. So I do think there's a big gap that could be improved on.
A good question, and I think Keith Pollard's right that that sort of real push in terms of supply and sort of at root what we've got is a sort of commercial impetus. I suppose the devil is in the detail in terms of trying to unpack in terms of regulation at what points and for what purposes, in terms of information, advertising, in terms of greater clarity around EQA forms, and even in terms of transparency. In the UK, for example, there has been some measure of success in terms of quality information systems, helping people to be able to have a look at comparing and looking across sort of particular providers. And so there's a range of ways you could think about that form of regulation. Clearly, we can't stop people traveling.
Monica Bless, the Nutrition Department. I would like to broaden the subject and get your comments on something that I recently heard. There was a Swiss politician who suggested to, in fact, send elderlies down to Morocco and install them there, and to get lower cost care, basically, but at the same time use the group down there to do some capacity building and get them involved in the culture down there and have people with skills there to teach young immigrants who went back to the country to use and apply the skills there.
Can you just clarify, so that the suggestion is older groups of Moroccan?
No. So to send Swiss elderly who, because we don't have enough EMS here capacity, to send them to install something in a different country and where it's beautiful and warm, and have them live there in a good environment, and at the same time use any skills that they have to exchange with the local population. Do you have heard any example of other countries where this was tried out? Is that something you think that could work? Is that any comment?
There's been some suggestions that within, I think, countries such as Turkey has been a potential base for sort of retirement, I suppose sort of almost organised retirement sort of villages. I think what's quite interesting is to look, it's not quite a direct comparison, but do take a look at some of the European experience to Spain and to France, and some of the issues around time lag, that what is chosen and interesting at one point in the life cycle very soon becomes something that is very isolating and a real challenge in another point in the life cycle. Certainly, again, there are a number of debates, though, that involve some of the larger retirement interests about those opportunities, and I can clearly see some of the overlaps with broader medical travel debates.
That I think with some of the key point up, I mean, there's some experience mostly driven not by state actors, but by firms who either sort of own retirement communities in Mexico and are encouraging Americans to come there, or obviously, patient and family, individual choice driven. In theory, although perhaps our ethics colleagues would like to comment on this, creating opportunities for a population to fill both medical and lifestyle need, if it's supported and by the population, that would not be seems like a sort of legal or ethical issue with that. Operationally, I think it could be quite difficult because of coming back to some of these questions about where does the issues of cost and risk lie, and it always increases when the state actors suddenly step in. I don't know, Marshall, if you have any comments on that?
Well, my comment would not be specific to this case, but in general, I think the ethical question is to look at the impact of new people coming to a country and having the possibility to bypass, for example, waiting lists. So what is the impact on the local health services? And this is also the same question we had before regarding equity. So it's not only providing services to people traveling for whatever reason or retiring in another country, but what is the impact for the local population of this because of the limited health resources? And I think this is the main ethical question.
And I think the question is, well, the one is, do people voluntarily retiring? But there's the question of care of the elderly. And I mean, certainly in the newspapers you read about Germans going to Croatia and the French sending people overwintering in Tunisia and things like that as a way of reducing the cost of care for the elderly. So this isn't voluntary retirement, it's sort of National Health Service or insurance company moving elderly people to other countries because it's just cheaper to look after them. Because, I mean, with the expansion of the aging population, either these countries have to import labour to look after these, or you're going to have to export the elderly to these countries. So I think it's going to become, I mean, what I've read in news, I don't know how big the scale of this is, or this is just wishful thinking at the moment. But I think it's probably a question that needs to be looked at.
Just to add to that, I think that's an extremely important point. There's been a number of just recent articles even this week. For instance, the BBC is running a story on the care for the elderly and the issues, that the tremendous burden that exists now, not only on the health systems, but even just on families where there's actually no formal support whatsoever for these caregivers. And, you know, some of the people in the room are probably involved with caring for people in that position. But I think that it's a huge issue. It doesn't come up, I mean, Neil can comment on this, doesn't come up so much in kind of the context of the medical tourism field, but if you relate this back to this question that I posed earlier of like what constitutes a healthcare system that offers integrated, you know, people and family-centered care, clearly there's no way that most of our aging populations, particularly in the Northern Hemisphere, are going to be able to cope with this massive, massive volume. And it's actually, I just saw recent estimates that look like in some estimates there'd be about 3 times what they thought it was in terms of cost in the coming years without innovative solutions. That could be one of them, depending on some countries' situations.
I mean, you know, the film industry has also caught on to this Hotel Marigold as the first thing of the Marigold Hotel. I mean, it's a fantastic critical sort of analysis of people from Britain moving to a rather nice part of India and then having mixed sort of responses to their new local conditions. There's also the issue of currency, because while a lot of hospitals that provide care to medical tourists, like the Apollo hospitals, you know, are in the commercial sector, it is actively encouraged sometimes by governments such as India, because these are foreign exchange spinners. So at one level, yes, these are commercial enterprises, but at another level, the governments themselves look at these as a wonderful way of earning, you know, US dollars, because I can't remember where this paper was published, but I'll dig it up. There is a study of Afghan nationals paying for the care in Apollo Hospital in dollars rather than in rupees. And this is actually legally now allowed in India, which some years ago was not. So even national government structures are changing in response to. So does that make them less sort of strict in implementing other guidelines? Because these are, you know, I think other ethical questions. Now, I know that the room is often used by the library for other meetings after 2. So I'd like to thank the 2 speakers for 2 very thought-provoking, informative talks. Thank you for, you know, the very wholesome contribution from the floor. I'd like to thank the funders, the Wellcome Trust, for funding us, all our WHO colleagues, and Alex from the Center for Global Health Histories, who've done a sterling job advertising the event. And most of all, to all of you for giving up your valuable time and joining us, and we hope you'll keep joining us for future Global Health Histories seminars. And thank you, Human. Now, I'm very happy to buy anyone who wants to continue chatting with our speakers some coffee in case our speakers particularly